As already discussed, you will promote adequate bowel function and administer stool softeners and analgesics as necessary. You will also teach your client breast care, breast and bottle feeding techniques, self-care, and infant care. You will also observe how the mother and the family unit are interacting with the newborn. Support their efforts and provide private time for bonding. How can you help your postpartum client feed her baby? Besides providing optimal nutrition during the first year of life, breastfeeding has many other advantages. Just one of them is that it stimulates uterine contractions, thus helping to prevent postpartum hemorrhage. So encourage your client to begin breastfeeding as soon as possible after delivery. The infant's quiet alert state during the first 2 hours after birth makes this an especially appropriate time to begin. Colostrum is the first fluid the breasts produce, beginning in late pregnancy and continuing for several days after birth. It is a yellowish fluid that contains antibodies, protein, and fat-soluble vitamins that nourish the baby until mature milk is produced. Colostrum's antibodies help the baby's immune system fight disease. About 2 to 4 days after birth, the breast produce transitional milk, a fluid that provides more calories than colostrum and is higher in fat, lactose, and water-soluble vitamins. Mature milk follows, and it looks thin, but it's nutritionally complete. Nipple soreness is often a problem soon after breastfeeding begins. To prevent sore nipples, teach your postpartum client to position the infant properly, making sure the entire areola is grasped, not just the nipple. Insert a finger between the baby's mouth and the breast to break the suction before removing the baby from the breast. Apply a few drops of breast milk to the nipples after feeding and allow them to air dry. Educate your client about the importance of keeping her breasts clean. She should wash them in the shower each day, but avoid using soap on her nipples because it has a drying effect. Teach her to wash her hands prior to feeding and to use disposable bra pads to absorb leaking milk. She must change the bra pads frequently to prevent infection. Recommend pads that do not have a plastic liner. The liner makes it difficult for the nipples to air dry. Breast discomfort in the postpartum period is usually due to engorgement, and in most cases it is transient. A good preventative measure is to make sure that the infant breastfeeds early and frequently, about 8 to 12 times within a 24-hour period. When your client is breastfeeding, help her position the infant and initiate early feedings when the baby is active. To assist the mother with the flow of breast milk, teach her that heat and massage applied just before feedings increases milk flow. You should limit the newborn to 5 to 10 minutes of sucking on the first breast, eventually increasing to 15 to 20 minutes. Instruct the mother to have no limit on nursing with the second breast, since sucking becomes less vigorous later in the feeding, although it is best to discourage non-nutritive sucking. She should also alternate the breast she uses to begin the feeding. If the areola is too engorged for the baby to latch on, teach the mother to express milk by hand or with the breast pump first. Assess the infant for coordinated sucking and swallowing at the breast. Teach the mother to breastfeed frequently and on demand. If her breasts are engorged, applying moist heat prior to her feedings and cold compresses after feedings might help relieve discomfort. Gentle breast massage before and during feedings is another helpful strategy. You might also instruct the mother about the warning signs of postpartum breast complications. If she has redness, swelling, fever, tenderness, and/or cracked nipples, she might have mastitis, an infection of the ducts and glands of the breast. It is uncommon in the early postpartum period, more often developing several weeks after delivery. Keep in mind that usually mastitis is only on one side, and the redness is localized. If your client has cracked nipples without other signs of infection, suggest she try a different technique for holding the infant, such as side lying, cradle, and football hold. These positions will take the stress off the nipple and not only promote healing, but will also help prevent further soreness or cracking. We've already mentioned frequent feeding, breaking the suction before removing the infant from the breast. Avoid non-nutritive sucking and applying breast milk to the nipples after feeding. You might also arrange that she confer with a lactation consultant for additional suggestions. Just remember, after pains are a common discomfort in multiparas during uterine involution, but the pain is increased when the mother breastfeeds. This is because breastfeeding causes uterine contractions by stimulating the release of oxytocin as the infant sucks. If your client is a first-time mother, she might experience a similar phenomenon when her baby breastfeeds, but it's usually not quite so uncomfortable. As you assess the breastfeeding infant, it is important to note for signs of insufficient feeding, dehydration, excessive weight loss, poor skin turgor, lethargy, sunken fontanelles, and decreased urine output. This is an urgent problem that requires intervention by the infant's primary health care provider. How will you approach the problem of ineffective breastfeeding? Now here's an example. MH gave birth to her first child 12 hours ago. She wants to breastfeed her baby, but she has not attended any parenting classes. She says, "I don't even know how to begin." From this information, you realize that this client knows very little about breastfeeding and needs your assistance with the basics. The nursing diagnosis for this problem is risk for ineffective breastfeeding related to lack of knowledge of breastfeeding techniques. The goals and expected outcomes associated with this nursing diagnosis are: by discharge, the infant will latch on, suck and swallow properly. By discharge, the infant will average 15 minutes per feeding. By discharge, the mother will demonstrate proper technique for removing the baby from her breast. And by discharge, the mother will verbalize satisfaction with breastfeeding. By discharge, the mother will verbalize confidence in her ability to breastfeed her baby. Your teaching plan for MH must be comprehensive. Begin with information about how milk is ejected. Let her know that in the early stages of breastfeeding, when she has her baby at the breast, it may take 5 minutes to activate the letdown reflex. Teach her that she is not to be strict about the length of feeding times, as long as her baby is positioned correctly on the breast. Improper positioning, rather than the length of time at the breast, is usually the cause of nipple trauma or sore cracked nipples. If she still feels that she needs more information on the general guidelines for breastfeeding duration, tell her to start with about 10 minutes on each side, changing sides when the baby is no longer sucking vigorously and swallowing. Stress the importance of having the baby feed long enough to empty the breast, and yet avoid prolonged or non-nutritive sucking. Offer these suggestions for preventing sore or cracked nipples. Properly position the baby on the breast. Avoid using a plastic bra liner. Change disposable pads frequently. Do not use soap on the nipples. Use a variety of positions for feeding. Break the suction between the baby's mouth and the breast. Apply breast milk to the nipples and let them air dry after feedings.